Hi everyone, I am Dr. Kiran Lakkireddy, consultant interventional cardiologist at Apollo Spectra Hospital, Amirpet, Hyderabad. Today I am going to brief on treatment options in the heart attacks due to the coronary blood vessel occlusion. So what are the management options in this scenario? Coming to introduction, what is heart attack? We already discussed in the previous video. It occurs due to atherosclerotic narrowing of the coronary blood vessels. So these are the right and left blood vessels where there is narrowing of the blood vessel. It is due to cholesterol accumulation in the blood vessel wall. So this leads to heart attack. So we classify heart attacks into acute and chronic. Acute means immediate emergency. Chronic is presenting with stable symptoms. So we call it as acute heart attack or acute coronary syndrome. They are again classified into two types: STEMI, ST elevation MI, and NSTEMI or unstable angina. Why you classified again acute coronary syndromes into two types means the treatment will change depends on the diagnosis of this condition into either STEMI or NSTEMI. So another syndrome is chronic coronary syndrome. It is presents with stable chest pain. So what is the mechanism of acute heart attack? The cholesterol fat accumulation suddenly bursts or ruptures with sudden occlusion of the two remaining blood vessel due to the thrombus accumulation. So this is cause of acute heart attack. In chronic coronary syndromes, there is gradual accumulation of the cholesterol and gradual narrowing of the coronary blood vessel lumen leading to symptoms. So what is the treatment options? So the emergency is the acute coronary syndrome, acute heart attack. There are two options here in the management, immediate management of acute heart attack. One is immediately taking the patient for coronary stenting, or to give a drug therapy to lyse, to break the clot which happened in the coronary blood vessel and to reopen the blood vessel. These are two modalities. So what is systemic thrombolysis? It is that the drugs, like some drugs called thrombolytics, will give streptokinase, tenecteplase, retiplase or altiplase. There are four classes of drugs. Will give these thrombolytics. That means they lyse the clot, they dissolve the clot. So these drugs will act in the manner of dissolving the clots, which is the cause for acute heart attack. So these drugs can be considered when the patient with acute heart attack with severe symptoms arrives to a hospital which is not having any dedicated cath lab team or cath lab facility. So and the patient is also not able to reach the hospital with the cath lab facility within 120 minutes. So in these type of scenarios, we can consider the systemic thrombolytics with the drug therapy. But if the patient is able to reach the hospital with cath lab facility within 120 minutes, percutaneous transluminal coronary angioplasty, that is implantation of a stent, is the best treatment when compared to the systemic thrombolysis with the drug therapy. So these are the two modalities. Among these two, coronary stenting is the better option, which helps in immediate restoration of the decreased blood flow beyond the block. So in this stenting, we pass a wire over that we place a stent immediately, and by placing a stent, we are opening the narrowed vessel and the blood flow is immediately restored. Okay, so we already know PTCA, called as in lay terms coronary stenting. What are the thing we are doing is the small metallic tubes we are implanting within the narrowed blood vessel, and there are different types of stents. Nowadays, every stent is drug-eluting stents only. So when the coronary stents need to be placed, when the stent need to be placed, okay, when the coronary angiogram for diagnosing blocks, we are doing coronary angiogram when coronary angiogram showing more than 70% narrowing of the blood vessel. More than 70% narrowing of the coronary blood vessel, stenting is must in symptomatic patients who are having symptoms. In these patients, stenting is must. And post-stenting, lifelong medication is compulsory. Okay. And then when a coronary stent is not required in the presence of blocks. So whenever the angiogram is showing less than 50% blocks, less than 50% blocks, we usually defer stenting. We don't stunt. And these patients should be continued on the optimal medical therapy with blood thinners and cholesterol lowering agents. So these are the two scenarios where we stunt or we not stunt. What happens when it is between 50 to 70%? We'll call it as intermediate stenosis. So what happens when it is there? What will we do? So in this scenario, we have to know whether this narrowing of the blood vessel is causing any problem in the heart. That is called like physiological testing, we will call. So there are different types of physiological testing. One is invasive called fractional flow reserve. We'll do this test to identify whether this block is causing ischemia, that is symptoms in the vessel supplied area. The vessel is supplying some amount of the heart myocardium. Whether this narrowing is cause problems in this area is not, we will test with this fractional flow reserve. This is called physiological invasive physiological testing. So we will usually stent. There is some number in this test where we suggest stenting and another number is there where we omit stenting. So when the FFR is less than 0.75, in these intermediate stenosis also requires stenting. So if there is no facility of this fractional flow reserve and the patient is not affordable, so what can we do? There are some other non-invasive techniques like SPECT myocardial perfusion imaging, which is a nuclear scan, or we can also assess by cardiac MRI or CT-FFR, and there is an angiographic based physiological study called angiographic viewer. They're all non-invasive tests which also helps in identifying whether that intermediate block will require stenting or not, whether it is causing ischemia in the blood vessel supplied area is not. If patient is not affordable for anything and these tests are not available and the patient is still symptomatic, we can consider sometimes in this type of scenario when the blood vessel supplying the myocardial area is large. That means the blood vessel, whatever area is supplying the myocardium, that area of the myocardium is large. If that supplying area of this vessel is large and if the stenosis, that narrowing is located in the origin of main blood vessels like in the initial part of the blood vessels, then if the patient is symptomatic in this type of scenario, we may consider stenting even in the intermediate stenosis in the absence of this physiological testing. So these are the important points when we will go for stenting and when we will not go for stenting. So what are the IVAS and OCT which are recently used in a lot of treatments? These are additional imaging techniques where we can clearly see, which provides lot of additional information and which helps in very good results of the coronary stenting. So we will, after keeping a wire in the blood vessel, we will pass these imaging catheters and we will analyze the what is that plaque is made of, what is that fat plaque is made of, whether it is a more fat or some fibrous tissue or some calcium is there. So we'll identify what is the characteristics, what is the length of that block, what is the size of the blood vessel. So is there any other, is there any branches across the plaque? So a lot of things we can clearly analyze compared to the conventional angiogram. So IVAS is a black and white images where we are passing a catheter into the coronary blood vessel and we are analyzing the plaques inside the artery. So in coronary angiogram we will see just the lumen, that is tube. We will only see the lumen, but we are not able to see anything what is inside it. Here with this imaging we can see inside the artery what is the fat plaque is made up of and how much size of the vessel is, what is the length of this narrowed segment, how much plaque burden is there, like how much plaque burden in that area is there. So we will get to know all these information, additional information. The same thing, there is another modality called OCT where we can clear more clear images with OCT, can clearly identify all the detailed minute details of the vessel architecture. Like there are 3 layers in the blood vessels like intima, media, adventitia, and we can clearly know what is happening in this layers and is there any thrombus present and any high risk features present in the fibrous plaque. We'll get to know a lot of information with these additional imaging techniques so that they help in a clear picture of the disease at that site of narrowing, and we'll able to make up a good decision like what is the amount of like size of the stent and length of the stent and up to where we can stunt it and how to do it. Is there any additional treatments required at this site? So like pre-stent information, before placing a stent, we can get type of plaque like lipid rich, fibrous or calcific, size of the vessel, length of the narrowed segment, any thrombus present, any complications like hematoma or dissections present prior to the stent. Post stenting, we'll get to know whether the stent after stenting with these additional imaging techniques will able to clearly identify is that stent is directly opposite to the wall or not. Is there any gap between the wall and the stent? Is the stent expanded to the vessel size or not? So we will get this adequate expansion and opposition of the stent to the vessel wall, and we can identify complications. Is there any dissections are there, hematoma are there, or that plaque has been prolapsing are there or not? So this kind of information we can get from this additional imaging. So we can deal with this. If any complications are there, we can dealt with very easy, and we can give you a better result for keeping the stent open for longer time and avoid the complications. So these are the new techniques which are being increasingly used nowadays, either IVAS or OCT imaging techniques, and which will give a very massive information regarding before stenting and after stenting. So this information leads to achieving best coronary stenting results and also leads to reduction of the major cardiovascular events. Like after stenting, this information will help in avoiding future heart attacks or future further requirement of stents. All these things will be reduced with these image guiding techniques. So all guidelines throughout the world now recommended image guiding coronary stenting for achieving best coronary stenting results. So imaging with IVAS, particularly these things are very useful in very like complicated lesions or complex procedures like calcific lesions where there is a huge calcium is there, which is very difficult to deal with. It will give a lot of information. Or whenever there is a branching from the vessel at the placement of the stent, it will give a lot of information. Or main portions of the vessel like ostium, like beginning portion of the vessel, or very origin of the blood vessel. These are very useful in stenting. Then another difficulty subset is while keeping a stent is calcific coronary blocks, which is like cement like hardness in the blood vessel. So what is it? Why it is a very problematic and why it is very important to consider calcium? So it is very hard to break with the routine ballooning. So with just like conventional ballooning, like simple balloons, you can't break the calcium. Why? What happens if you can't break the calcium? If you can't break the calcium, the vessel will not expand properly. So after you keep a stent, there is inadequate expansion. It will not expand to the vessel size, and it leads to further complications in the future. So this calcium needs to be adequately treated before stenting. So if you don't treat adequately and you do direct stenting without treating it properly, you will end up in future repeat stentings and repeat heart attacks will be more. So there are a lot of techniques to deal with this calcium. If there is severe calcium, there are techniques called rotational atherectomy where a small burr is there, so a diamond shaped burr. So it rotates at higher speeds and breaks the calcium into small particles and clear the path for stenting and results in good expansion. And another one is orbital atherectomy where it is rotation like in a circular manner and treats the calcium and breaks the calcium. This is the circular manner. It will rotate at different speeds. It will go to different lengths around the circle. There's another technique called intravascular lithotripsy, where a balloon is placed when a balloon is able to cross across that at calcific lesion. We pass this special type of balloon, and we will give ultrasound impulses to break the calcium. So it results in breakage of both superficial and deep calcium, the calcium which is just close to the vessel and also to the deep calcium away from the lumen. So it breaks both the calcium effectively. And another new technique, when you are not able to pass anything across this calcific lesion, we can consider laser atherectomy where it will give a small passes and later you can convert to rotational atherectomy or orbital atherectomy. So these are the different techniques used to break calcium. And if there is a simple or less severe calcium, there are simple, like special balloons like cutting balloons or scoring balloons where there is small blades over the balloons and it will crack the calcium. Or you can use very high pressure non-compliant balloons where you can inflate the balloon to a very high pressure. So with that pressure, it can break the minimal calcium, whatever is available. So these are the special techniques we will use to break the calcium and achieving the best good result during the coronary stenting. So there is a DEB or DCB and the newer treatment option which is called drug-eluting balloon or drug-coated balloons. So in which there is a layer of drug is coated on the balloon surface. So when the balloon is inflated, these drug particles on the balloon surface will be transferred to the intimal layer of the coronary blood vessel where these particles, drug particles are absorbed into the blood vessel layers. So before treating with this drug coated balloon, whatever the narrowed vessel should be adequately treated, like it should be properly prepared so that it should be properly expanded before treating with the drug coated balloon. So when will you consider this drug coated balloon or drug eluting balloon? After proper treatment of the vessel, if that flow beyond the stenosis is good, there are no complications at that site of the stenosis and the vessel is expanded to the native vessel size or the good size, then that lesion can be treated with drug eluting balloon or drug coated balloon without a stent. This is the procedure. First we will prepare the balloon like narrowed segment. We will open with regular balloons or cutting or special balloons. We will expand this lumen. After this we will apply the drug coated balloon to the vessel wall so that the drug will be absorbed into the blood vessel wall without the requirement of a stent and prevents further progression of the atherosclerosis and it will halt the further accumulation of the flat and causing stenosis. So these are specifically useful right now in the diffuse long segment narrowing where there is a very big segment of disease and causing severe narrowing where you can't place a stent but you want to expand the vessel to reasonable size, then you can dilate the vessel and apply this drug coated balloon. So this is one subset where it is very much useful, diffuse long segment narrowing. And even smaller coronary blood vessels like small blood vessels having severe disease, in these blood vessels also you can place a stent, so we can treat with the smaller coronary blood vessels and smaller branches where we can avoid the unnecessary placement of a stent, so we can treat those also with drug coated balloon. Nowadays it is increasingly used and a lot of trials are going on to treat with the drug coated balloon and avoid the stunting wherever not necessary based on some specific criteria on imaging like IVAS or OCT. So it's like this way it may help in reducing the number of stents placed and if the result is good with the drug coated balloon. But lifelong medical therapy with the blood thinners and cholesterol lowering agents is mandatory after all these procedures. Whatever the procedure you do after a heart attack or you're having a narrowing of the blood vessels, you require blood thinners and cholesterol lowering agents. So this is compulsory and one should be kept in mind. After doing the procedure also, you should continue this medical therapy lifelong. Thank you everyone. I am Dr. Kiran Lakkireddy. I thought I enlighten you the general public on the coronary stents and treatment modalities, different treatment modalities while stenting in the coronary blood vessels during heart attacks or having a chest pain. So I am Dr. Kiran Lakkireddy, working as interventional consultant interventional cardiologist at Apollo Spectrum Hospitals, Amirpet, Hyderabad. So I expertise in coronary stenting, different forms like primary angioplasty in heart attacks, left main stenting, bifurcation stenting, stenting of calcific coronaries and chronic total occlusions. You can do IVAS or OCT guided coronary stenting and using drug eluting balloons. Also do pacemakers, ICDs and CRT. We'll do structural heart interventions like balloon valvuloplasty, TAVI, heart hole device closures, peripheral angiograms and interventions where there is a narrowing of the blood vessels in the hands and legs. We can keep IVC filters, or we can also expertise in aortic stent graft for aortic aneurysm and dissection. Thank you one and all. Thank you very much.